Hello everyone, my name is, I think I'm too tall for this. Hello everyone, my name is Isaac. I'm a research nurse from the Anne Rowling Clinic in Edinburgh, and today I'll be discussing a cross-sectional analysis that my colleagues and I did to evaluate the MND nursing and allied health professionals workforce, where we've generated themes and discussions based on the evaluation. As many of you already know, MND is a fatal and devastating disease, but what I would like to highlight for all of you today is that it requires an extensive multidisciplinary team to fully support our patients with MND. This is also one of the recommendations from the National Institute for Health and Care, the NICE guidelines that underpins how we deliver effective and supportive MND care from our healthcare professionals. And from this, we know that the MDT is an essential component to delivering effective MND care. So this begs the question, how is the MDT doing? And within the scope of my practice and my remit, how are the nurses and the allied health professionals doing? Therefore, we recognize the importance of evaluating this workforce, and in particular, the nursing and allied health professionals team, where it is mostly unknown within the literature. Within the literature, there is a vast gap in the knowledge of the workforce itself, whether it is the knowledge of the demographics of the workforce, the compliance with national frameworks and standards, and the experiences and well-being of the workforce itself. And we hope that we could shed some light with our research. Therefore, there was a unique opportunity that arose in the inaugural UK MND NAHP gathering in November 2023 that was held in Edinburgh. This was the first known meeting among all the MND workforce that invited all the nurses, all the care coordinators, occupational therapists, physiotherapists, research nurses, and other allied health professionals, such as dietitians and respiratory services from across the UK, with individuals coming all the way from the Shetland Islands to the Isle of Man. From this, we wanted to make use of this rare and unique opportunity by coming up with some of the aims to explore this workforce. This includes, what is the size of the workforce? Are they complying with national frameworks and standards? And what are their experiences and how is their well-being? And we hope that we could link these to some demographic factors as well. And so to meet the aims of the study, we employed a pragmatic approach which allowed us to be more flexible in our methodology, and we made use of the convergent mixed methods approach. This means that after collecting the quantitative and the qualitative data, we were able to analyze and collate both the data sets together to create broader themes and sub-themes. This data was collected through a cross-sectional census, online or paper questionnaire survey, as you can see on the left. Demographic data and work-related characteristics were collected. General compliance with the NICE guidelines and the MND nurse competency framework was assessed through multiple choice questions, and Likert scales and free text boxes were used to assess satisfaction and the feelings of being valued. The burnout assessment tool, core and secondary, also called the BAT-C and the BAT-S, is an externally validated and reliable test that uses several questions to assess different aspects of burnout. It makes use of a traffic light system to determine different risks of burnout, as you can see on the right. The quantitative data was analyzed using the statistical software R, where we use chi-square tests and one-way ANOVA tests for continuous data sets, and the qualitative data was analyzed using the content analysis framework, and we used the NVivo 14 qualitative software to organize our themes and sub-themes. And so overall, we obtained 64 responses, which was 75% of the 80-plus attendees of the meeting. And so this data may not be representative or generalizable. However, there are much themes and results that I would like to highlight. When assessing the demographics data, we can see that the respondents were mainly from Scotland and England, female, white British, and 41 years or older. Looking further at the demographics data, there are some interesting points that I'd like to highlight. The first in which it is a highly qualified workforce, which we can see 70% of the respondents have obtained a bachelor's degree or higher, which is reflected in a large number of respondents being in a senior level member of staff. While this represents a highly qualified workforce, almost 50% of them are not working full-time. Looking into the employment demographics, we can see in the first table, there are fluctuations in the number of months worked in MND care, number of patients in their caseload, and the time in their current posts. And this is based on the high standard deviation in the 3 columns. This can be actually considered quite positive because it reflects a good balance between those more experienced members of staff and those who are more junior and those who have just started out in their role. I also want to point out that 30% of the respondents highlighted vacancies within their core MDT, which I will link to the themes that we've generated later on. And so the first theme that was generated is the benefits of the multidisciplinary team. When we first got involved looking into the qualitative data, one of the initial and the most prominent themes was how a supportive and extensive multidisciplinary team is imperative and essential for almost every respondent, as we can see in some of the quotations in the slide. We can see a high percentage of respondents have an established relationship with many members of the core MDT, and this aligns with the NICE guidelines, and we can see this shows a high level of support for the UK MND NAHP workforce. Furthermore, more than 80% of the clinical professionals reported a relationship with respiratory services, gastroenterology services, wheelchair services, and assistive technology services, which are crucial relationships to aid in supporting our patients. This is important to note because this does align with the NICE guidelines, where it stipulates that the multidisciplinary team should have established relationships with the following services. However, on the flip side, there is a notion where when there are vacancies and limitations within the core MDT, it affects negatively for the healthcare professionals itself and also the patients. As we can see in one of the quotations written in the slide, there is a knock-on effect when teams are short-staffed. Furthermore, we identified a lack of established relationships with services such as counseling and neuropsychology from both the quantitative and the qualitative data. And this relates to what was previously mentioned, where 30% of the respondents are reporting vacancies within their core MDT. Relating this to the wider literature, many researchers have highlighted the benefits of the MDT and how imperative some of the specialties, such as the palliative care specialists, are to ensure patient-centered care and optimal health benefits for our patients. The second theme that we've developed is the notion of roles and responsibilities. Again, overall, the qualitative data shows that most of the respondents are very happy about their job. Specifically, when looking at the clinical professionals, many respondents reported benefits of the job such as flexibility, autonomy, and developing a wide range of competencies in such a challenging and evolving environment. This may relate to the notion of seeing high percentage of attainment in competencies surrounding provision of information and expertise, acting as an advocate for the patient and their family, and leading and collaborating within the MDT. However, reading down the table on the right, we can see that there are some competencies that have low engagement. For example, competencies such as muscle management, respiratory analysis, and specialist medication management, which includes the use of Botox. This links with the qualitative data where the respondents mentioned the potential issue of a nebulous definition of what the MND service can provide, and this can cause some differences in expectations from our patients, as you can see in the quotation on the bottom left. Some other members of staff may not know the full remit of what the healthcare professional's job is, and this can cause the patients to expect more than what the service can provide. And lastly, I'd like to point out that there may be geographical differences between the job roles, and this can cause inequitable care and issues within delivering the care. The final theme that we've developed is benefits and challenges in providing direct care. In this theme, we can see impressively high satisfaction and valuation scores shown in the table, where 100% of the respondents felt often or always valued by patients and their families. And a high proportion of respondents said that they felt valued by other healthcare professionals within and outside the MDT. Extending this discussion into the burnout scores, again, we see an impressively high rate of low risk of burnout, with 78% of respondents are at low risk of burnout. This can be related to the qualitative data, where some of the respondents expressed sincere gratitude for the individuals that they were taking care of. While the work may be perceived as challenging, the respondents felt content with their job role, and they received much satisfaction from their work. However, by further breaking down this data, we can see that a higher percentage of non-clinical healthcare professionals had a lower risk of burnout than their clinical colleagues, which is what you would expect. However, looking into the data, there are still 14% of overall respondents who are at risk of burnout, and 6% of them have already burned out. Furthermore, 8% of the clinical colleagues are more likely to have already burned out. Looking more closely with the total BAT scores, the exhaustion subsection of the burnout questionnaire showed that almost 25 of the respondents were identified as a medium to high risk of burnout that has similar rates seen in the emotional and cognitive impairment subsections, which highlights some nuances in the data. For example, when we further consulted some of the respondents, they have suggested that there may be some limitations to our cross-sectional methodology, where if this was asked to them in another day, their questions and their responses may be different, and you could see the results being worse, and this highlights a need for further assessment and review. This links with some of the identified challenges in providing direct care as described in the qualitative data. This refers to some of the respondents saying that there may be organizational barriers. Some of them actually commented that they are facing some funding difficulty and a lack of resources, meaning that there is a mismatch between what the patients need and what they could provide. Furthermore, some of the respondents also commented on feeling isolated, where many of the respondents are lone working. When linking this to the wider literature, we can see similar issues where organizational barriers and burnout can negatively impact patients. Where there are some limitations to our report, given the small sample size and the potential for bias, there are large amounts of implication. There is a need for a national standardized competency and job definitions that can be achieved through education and policy. Further resources are needed to address the issues with compliance to national frameworks and identify organizational barriers to reduce the issues of inequitable care. And further research should be performed to offer longitudinal assessment and consultation with the workforce, and to better understand the demographics, compliance, and mental well-being of the workforce. This may offer a unique opportunity to maintain a resilient and effective workforce. And to assist in these implications, we are currently working with the University of Edinburgh to develop a master's level course, and we are currently formulating a dissemination plan to submit this into a research journal and to attend conferences and to disseminate our lay brochure, which you can use the QR code to view the brochure. So in conclusion, I would like to say that the census has provided novel and valuable insights into our workforce. We have developed themes such as the benefits of the MDT, the roles and responsibilities, and the benefits and challenges in providing direct care. While there are some limitations, we have addressed that there is a need for education and policy change and to address any organizational barriers. I would like to thank the UK MND NAHPs for contributing to this finding. I'd like to thank the 4 charities for funding the inaugural gathering. And I'd like to thank the Ann Rowling Clinic for funding this important work. Thank you.
Thank you, Isaac, for that. It's a really fascinating presentation. I can see lots of hands here. Jess.
So I've got a question from Sue Nelms from MNDA in the virtual room, and she's asking, what actions should be taken to protect MND nurses from burnout? Relationships are important, but that will also impact on the well-being of nurses.
That's a really good question. So during that meeting, when that question was brought up, a lot of ideas were being shared by the nurses themselves, actually. And I think some of you in the audience right now were there in that meeting. But a couple of things were brought up, just developing preventative burnout strategies. You want to be not reactive, but proactive in how we can maintain a resilient workforce. So looking into the organizational barriers within different health boards in the UK are very important, and addressing that with the senior management team is very important as well.
I have a question for you, Isaac. You concentrate a lot on burnout. Now, I associate burnout with the systemic environmental pressures, like lack of time, lack of equipment, and things like that. What really affects, I think, healthcare professionals is compassion fatigue. Is that something you thought about or looked at kind of measuring in any way?
Was it compassion?
When fatigue, when you give, and then you can't give any more, and you get little back. Nurses and healthcare professionals suffer a lot from compassion fatigue, I think.
Yeah, that is extremely important. I think one of the senior research nurses in Edinburgh, her master's was on compassionate care for the healthcare professionals. We can definitely disseminate this with her and look into how we can provide that for starting with the nurses in Scotland, and then we can disseminate that to the rest of the UK.
Okay, thank you. Are there any other questions here? Okay. Isaac, I'd like to thank you very much for your presentation.